First, let us start with the nephrology. So this particular PDF of this nephrology revision has already been shared on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. So you can download this PDF from my Telegram channel. Okay, right. Now, what are the topics that I'll be discussing in the nephrology is I'll be discussing urine analysis, acute kidney injury, chronic kidney disease, nephrotic syndrome, nephritic syndrome, polycystic kidney disease, and then followed by that, we will also be discussing renal tubular acidosis. These are the very important topics which I'll be discussing now. Right. Now, starting with the urine analysis first. So in the urine analysis, you need to be completely aware of this very important terminology called proteinuria, right? So if you take this proteinuria, what is the normal quantity of the proteinuria? The normal quantity of total proteinuria will be less than 150 milligrams per 24 hours. But among this entire proteins, the protein which is excreted out in larger quantity will be the albumin. And how much will be that albumin that is being excreted? Less than 30 milligrams per 24 hours. That is the normal albuminuria. And how do we detect the proteins in the urine? That is by urine dipstick test. But the point you need to remember is the urine dipstick test can detect only negatively charged proteins. But this positively charged proteins, they cannot be detected in the urine analysis. What are those positively charged proteins? The positively charged proteins, they are globulin that cannot be detected by the dipstick test. So if there is presence of the globulin, right? If there is presence of the globulin, you will have a false negative, right? You will have false negative report upon urine dipstick test if there is presence of the globulin. Now, the point you need to understand here is when the quantity of albumin is increased more than 30 milligrams per 24 hours, then we call it as the significant albuminuria. Accordingly, we have microalbuminuria and macroalbuminuria. But this particular terminologies, microalbuminuria and macroalbuminuria, has been replaced with moderate albuminuria and severely increased albuminuria. These are the two terminologies that have replaced micro and macroalbuminuria. Now, what is the way by which they are being replaced? So previously, we used to calculate the albumin excretion per 24 hours. But what has happened is there is false collection of the sample by the patient. Either there might be an under collection or there might be an over collection of the sample. That is the reason why rather than measuring the proteinuria or albuminuria in 24-hour urine sample, present day, what we are doing is we are detecting the protein in a spot urine sample. In the spot urine sample. Okay. So in the spot urine sample, what is that we are measuring? We are measuring the quantity of the proteins in milligram, right? The quantity of the proteins in milligram per gram of the creatinine. The quantity of the protein which is excreted in milligrams per gram of creatinine. Now, what is the criteria for moderately increased albuminuria? That is 30 to 300 milligrams per gram of creatinine, whereas severely increased albuminuria, the terminology is more than 300 milligram per gram of creatinine. So, moderately increased albuminuria, 30 to 300 milligram per gram. Severely increased albuminuria, more than 300 milligram per gram of creatinine. Now, when do we use this term called overload proteinuria? Overload proteinuria is that when the quantity of the proteinuria is more than 3.5 grams per 24 hours, like in cases of nephrotic syndrome, we use this terminology called overload proteinuria. Now, in the urine dipstick test, we quantify the proteinuria as trace 1 plus, 2 plus, 3 plus, and 4 plus. Now, when do we use this trace? We use the word trace when the quantity of the proteinuria is around 15 to 30 milligrams per deciliter. And when do we use this terminology 1 plus? When the quantity of the proteinuria is around 30 to 100 milligrams per deciliter. And when do we use this terminology 2 plus? When the quantity of the proteinuria is 100 to 300 milligrams per deciliter. And when do we use this terminology 3 plus? We use that when the quantity of the proteinuria is we use that when the quantity of the proteinuria is 300 to 1000 milligrams per deciliter. Then when do we use this terminology 4 plus on the urine dipstick test? When the quantity of the proteinuria is more than 1 gram per deciliter, that is when we use the term called 4 plus. So in this way, in the urine dipstick test, you have 1 plus, 2 plus, 3 plus, 4 plus, and as well as the trace. Now, the proteinuria can happen due to glomerular pathology, or the proteinuria can happen due to tubular pathology also. Now, what will be the quantity of the glomerular proteinuria more than 3.5 grams per 24 hours? What is the quantity when there is tubular proteinuria that is less than 2 grams per 24 hours? Okay, so that is what is the difference between the glomerular and tubular proteinuria. So this completes the discussion of the proteinuria. Next, very important is you need to be completely aware of the caste, that is RBC caste and as well as the WBC caste. What exactly is the caste? Caste is nothing but it is formed due to precipitation of Tam Horsfall protein with abnormal substances, right? It is formed due to precipitation of Tam Horsfall protein with abnormal substances. That is what will result in the formation of the caste. And you take the RBC caste. RBC caste is nothing but the RBC, when it combines with Tam Horsfall protein, that will result in RBC caste. Where exactly is the caste formed? Caste is formed at the level of distal convoluted tubule. Now, what are the conditions where you will have RBC caste? RBC caste, it is present in glomerulonephritis, vasculitis, and as well as the hypertension. Then, what are the conditions where you have the presence of the WBC caste? WBC caste, it is present in conditions like pyelonephritis and as well as the allograft rejection. These are the two conditions where you have the presence of the WBC caste. And the next important is the presence of the pigment caste or the granular caste. That is observed in conditions like acute tubular necrosis. In acute tubular necrosis, you will have the pigment caste or the granular caste. And you also observe this, and this acute tubular necrosis, it is caused by hemoglobinuria and as well as myoglobinuria. Then the conditions where you will have eosinophiluria, it is observed in allergic interstitial nephritis and atheroembolic diseases. Then the conditions where you will have crystalluria within the urine sample, that is observed in uric acid nephropathy, which is nothing but gouty arthritis, right? Or gouty nephropathy. And it is also observed in conditions like ethylene intoxication, right? Ethylene intoxication, you will have the presence of crystalluria. That was about the caste. So we have discussed about proteinuria and we have discussed about the presence of the caste. Now let me discuss about the hematuria. Now, when do you call it as the microscopic hematuria? We use the term microscopic hematuria when the quantity of the RBC is more than 3 per high power field. When do you call it as significant or persistent hematuria? Significant or persistent hematuria is said when the quantity of the RBCs are more than 5 RBCs per high power field, right? Now, if there is presence of dysmorphic RBC within the urine sample, what is it suggestive of? It is suggestive of the glomerular pathology. What are the conditions where you have the presence of the red urine? The conditions where you have the red urine, it is observed in case of the clofazimine and as well as the porphyrins. These are the two conditions where you have the presence of the red urine. Now, if there is a combination of hematuria, pyuria, and as well as bacteriuria, right? If there is a combination of hematuria, pyuria, or bacteriuria, that is suggestive of the pyelonephritis. And if there is presence of the oval fat bodies, that is observed in case of nephrotic syndrome, fat embolism, and as well as chyluria. These are the conditions where you have the presence of the oval fat bodies, nephrotic syndrome, fat embolism, and chyluria. Then, what are the conditions where you have the presence of Maltese cross appearance within the urine sample? Maltese cross appearance in the urine sample is observed in two conditions. One is Fabry's disease and the other condition is in cases of nephrotic syndrome also you can have the presence of Maltese cross appearance. So this is about the abnormalities related to the urine analysis. So in 1 minute, I'll just quickly recap the urine analysis. So regarding the proteinuria, normal total proteinuria less than 150 milligrams per 24 hours, normal albuminuria less than 30 milligrams per 24 hours, right? And the dipstick test will detect only negatively charged proteins, that is albumin. Moderately increased albuminuria, 30 to 300 milligrams per gram of creatinine. Severely increased, more than 300 milligrams per gram of creatinine. And you need to be completely aware of 1 plus, 2 plus, 3 plus, and 4 plus. So 1 plus is 30 to 300, 2 plus is 100 to 300, 3 plus is 300 to 1000, and 4 plus is more than 1 gram per deciliter. RBC casts are present in glomerulonephritis. WBC cast is present in pyelonephritis. Then the pigment cast are present in case of the acute tubular necrosis. Eosinophiluria is observed in allergic interstitial nephritis. Crystalluria is observed in uric acid nephropathy. Microscopic hematuria, that is observed in microscopic hematuria, the criteria is more than 3 RBCs per high power field, significant more than 5. Dysmorphic RBCs, if it is there, that is suggestive of glomerular bleed, right? Oval fat bodies are present in nephrotic syndrome, Maltese cross appearance in Fabry's disease. So this is about the urine analysis. Done? Now, so eosinophiluria, I was telling one more condition. Apart from allergic interstitial nephritis, what is another condition where you will have eosinophiluria? Yeah, Rituraj Sahu, minimal change disease is the disease which have very good prognosis. So you don't worry about it. The prognosis is very good in case of minimal change disease. You will have this in case of atheroembolic disease. In atheroembolic disease, you have the presence of the eosinophiluria, right? Next, we'll move on to, yeah. And in the urine analysis, you should also be aware of the colors of the urine. Pink urine, you will have in desferoxamine toxicity. Pink diaper sign, it is observed in the infection caused by Serratia marcescens. Red urine, it is observed in clofazimine and as well as porphyrins. Cola colored urine, observed in post-streptococcal glomerulonephritis. Black color urine, observed in paroxysmal nocturnal hemoglobinuria and as well as paroxysmal cold hemoglobinuria. And the conditions where the urine will turn into black in color on exposure to air, that is observed in case of the alkaptonuria, right? So this is about the urine analysis story, right? Now, after having done about the urine analysis, we'll move on to the discussion of acute kidney injury. What is the definition of acute kidney injury first? Acute kidney injury, we define it by 2 points. One is rise in serum creatinine. Second one is decrease in urine output. So if you take the rise in serum creatinine will be more than, it will be more than 0.3 milligrams per deciliter within 48 hours. That will be increase in serum creatinine. Or the increase in serum creatinine will be more than 1.5 times the normal within 7 days. That is one parameter where there will be increase in serum creatinine. And second important parameter will be decrease in the urine output. Decrease in urine output will be less than 0.5 ml per hour for nearly around 6 hours. These are the 2 points which are taken into the consideration of the definition of acute kidney injury. Now, what are the etiologies that will be causing acute kidney injury? The etiologies that will be causing acute kidney injury will be pre-renal type of acute kidney injury. In pre-renal type of acute kidney injury, what will happen is the renal perfusion will be reduced. Now, what are the conditions where the renal perfusion will be reduced? Whenever there is decreased intravascular volume, like in case of hemorrhage, vomiting or diarrhea, or in conditions like decreased cardiac output, that is observed in patients with the congestive heart failure. And it is also observed in renal vasoconstriction, like in hypercalcemia and sepsis, and impaired autoregulation, that is observed in case of the ACE inhibitors and as well as the NSAIDs. These are all the etiologies that will be causing pre-renal type of acute kidney injury. Whereas the intrinsic type of acute kidney injury, the problem is within the kidney itself, right? Now, one of the very important etiology causing intrinsic renal will be acute tubular necrosis. And this acute tubular necrosis, it can occur secondary to ischemia, or it can occur secondary to the exogenous or the endogenous toxins. What are the exogenous toxins? Like aminoglycosides, basically the antibiotics. What are the endogenous toxins? Like hemoglobinuria, myoglobinuria, light chains, that is observed in case of multiple myeloma and tumor lysis syndrome. These are the conditions where you will have acute tubular necrosis. We have one important drug that will be causing the acute tubular necrosis, that is contrast-induced nephropathy, which is very common in patients with diabetics. And this contrast-induced nephropathy, what is the treatment is? The treatment is N-acetylcysteine, and we give IV fluids, that is normal saline, for the treatment of contrast-induced nephropathy. And what is the most common tumor that will be causing the tumor lysis syndrome that can contribute to the development of acute tubular necrosis? That will be Burkitt's lymphoma, right? Staph aureus. I'll answer your question. NSAIDs, let me tell you, it can cause pre-renal, right? It can cause intrinsic renal. Okay, and what is the mechanism of intrinsic renal? The NSAIDs will cause papillary necrosis, or sorry, it will cause interstitial nephritis. So it can cause both. And NSAIDs can also cause chronic kidney disease. How it will cause chronic kidney disease? That is by renal papillary necrosis. That is by renal papillary necrosis. Like you will have the development of chronic kidney disease by the NSAIDs. So NSAIDs can cause everything: pre-renal, intrinsic renal, or even it can also cause chronic kidney disease as well. Staph aureus, is that clear? Now, what are the electrolyte abnormalities that you come across in patients with the tumor lysis syndrome? Hyperkalemia and as well as the hyperuricemia. So how do you treat these patients with tumor lysis syndrome, which will be causing acute tubular necrosis? Right, number one, hydration. And the next one is rasburicase. That is considered as drug of choice in patients with tumor lysis syndrome. And we need to give xanthine oxidase inhibitor, that is allopurinol. That is given as the chronic therapy that will reduce the uric acid synthesis. That is what you observe in case of the tumor lysis syndrome. Now, one more important drug that will be causing the acute tubular necrosis is the ethylene glycol intoxication. Now, what exactly is ethylene glycol? Ethylene glycol is an antifreeze which is used in the fuel to see that the petrol and diesel will remain in a liquid state. That is what is your ethylene glycol. And this ethylene glycol intoxication will cause the calcium oxalate crystals, and that can cause acute tubular necrosis. And the antidote that you need to give for ethylene glycol intoxication is fomepizole. That is a drug of choice for ethylene glycol intoxication. Then you see in case of the atheroembolic diseases. Atheroembolic diseases, they also will cause damage to the kidney, or that will cause the intrinsic renal failure. And these atheroembolic diseases, they are mainly due to rupture of the atherosclerotic plaque. And this atherosclerotic plaque, when it is being ruptured, emboli will enter into the kidney, resulting in the atheroembolic diseases. And that will cause eosinophilia and eosinophiluria. And in atheroembolic disease, you have an important cutaneous manifestation that is called livedo reticularis. And in atheroembolic disease, the emboli can also enter into retinal circulation, and that will result in the development of the Hollenhorst plaques. And what will be the blood picture in patients with the atheroembolic disease? You will have eosinophilia and as well as the eosinophiluria. That is what you observe in case of the atheroembolic disease, right? Then, followed by that, you should be completely aware of how to differentiate pre-renal from the intrinsic type of renal failure. Very, very important parameter is this one. That is fraction excretion of sodium in pre-renal will be less than 1 and intrinsic renal will be more than 1. This is what you need to remember, how to differentiate these two. And I have also given you some other parameters. You can go through that. But the other one that you have to remember is this one. Blood urea nitrogen to creatinine ratio. In pre-renal, it will be more than 20, and in intrinsic renal, it will be less than 10 to 15. So that is how you will differentiate pre-renal from intrinsic renal. Next, you need to be completely aware of the workup that you do in patients with acute kidney injury. What are the various electrolyte abnormalities? Please remember, all the electrolytes are increased except for sodium and calcium. Why sodium is reduced? Because of dilutional hyponatremia. Why calcium is being reduced? Because calcium will combine with the increased phosphate that will result in calcium phosphate. So there will be hypocalcemia. And the electrolytes which are increased is potassium, magnesium, phosphate, and as well as increase in uric acid and increase in blood urea nitrogen. These are the electrolytes. Now, what is the purpose of doing imaging? The purpose of doing the imaging is mainly to diagnose the post-renal type of acute kidney injuries. What are the etiologies that will be causing post-renal type of acute kidney injury? That is benign prostatic hyperplasia, which is the most common cause of post-renal type of acute kidney injury in males. That is post-renal type. nephrolithiasis, that is ureteric stones. And if you see the treatment in patients with the acute kidney injury, so treatment for the contrast-induced nephropathy, drug of choice will be N-acetylcysteine. And treatment for the tumor lysis syndrome, drug of choice will be rasburicase or the allopurinol. And the treatment for rhabdomyolysis will be forced alkaline diuresis. And the treatment for the volume overloading, because in acute kidney injury, there is volume overload. So fluid restriction, and you need to give diuretics like furosemide. And these patients, they have to be given 3% sodium chloride only when they have development of the clinical features like altered sensorium and as well as seizures because of dilutional hyponatremia. And because of the fluid overload, they can develop hypertension, for which you need to give labetalol. Usually, medical management will suffice, but there are some indications where you need to do dialysis in patients with acute kidney injury. And you can remember the mnemonic for the requirement of dialysis, that is HAVP, where H stands for refractory hyperkalemia. H is refractory hyperkalemia, right? And A, okay, refractory hyperkalemia is H. A stands for refractory acidosis. V stands for refractory volume overload. E stands for elevated blood urea nitrogen more than 35 millimoles per liter. The word P stands for the pericarditis. The word E stands for the encephalopathy. And the last word E stands for the pulmonary edema. So these are the indications where you need to do dialysis, right? This is about acute kidney injury. So in case of the acute kidney injury, to quickly recap, what is that you need to remember? One is the important definition. What is that important definition? Where you have increase in serum creatinine and as well as decrease in urine output. The etiologies will be pre-renal, intrinsic renal, and post-renal. Pre-renal mainly due to decreased perfusion, intrinsic renal where the pathology is in the kidney, post-renal where the pathology is outside the kidney. And the clinical features will be due to volume overload or due to increase in the urea and as well as creatinine. And the treatment, you need to treat the underlying etiology, and you should be completely aware of what are the etiologies where you need to do dialysis in acute kidney injuries, right? So that was about the acute kidney injury. Now we'll move on to the chronic kidney disease. Okay. So if you take the definition of chronic kidney disease, what are the two parameters which are taken into consideration for defining chronic kidney disease? One is GFR, where there is decrease in GFR to less than 60 ml per minute per 1.73 meters square. And proteinuria should be there for nearly around 3 months. So these two are the points which are taken in the definition of chronic kidney disease. Now, in case of chronic kidney disease, what is the most common cause for the chronic kidney disease? Most common cause for chronic kidney disease will be diabetes mellitus is the most common cause, right? Now, what are the clinical features that you come across in patients with the chronic kidney disease? The clinical features that you will have is due to increase in the fluid load in the body. And the next important is the increase in the urea and as well as creatinine. Now, what are the features that you will have due to fluid overload? The cardiovascular manifestations in the form of hypertension. Then the pleural abnormality where the fluid accumulates in the pleural space resulting in pleural effusion. Pericardial space, there will be fluid accumulation resulting in pericardial effusion. And in the peritoneal cavity, the fluid gets accumulated that will result in the development of ascites. In the lower limbs, the fluid can get accumulated that will result in pedal edema. So these are the features due to the fluid overload. Then what are the features due to increase in urea and as well as creatinine? So urea, it will cross the blood-brain barrier resulting in uremic encephalopathy. Urea can accumulate within the pericardium resulting in uremic pericarditis. Urea will also accumulate within the GIT causing uremic gastroparesis. Urea will also accumulate within the peripheral nerves causing peripheral neuropathy. Urea will also accumulate within the skin resulting in xerosis. Urea can also accumulate within the eye resulting in band keratopathy. Now, what are the metabolic abnormalities? Metabolic abnormalities in chronic kidney disease will be acidosis. Why there is acidosis? Because of impaired excretion of ammonia. That is one reason. Second important reason is due to increased bicarbonate excretion. These are the two reasons why there will be development of the acidosis, right? Now, what are the electrolyte abnormalities? The electrolyte abnormalities will be hyperkalemia, hypermagnesemia, and as well as the hyperuricemia. These are the three important electrolyte abnormalities or metabolic abnormalities that you will have. Then next important is hyperphosphatemia. But the electrolytes which are reduced, that will be hypocalcemia and hyponatremia. These are the two important abnormalities of the electrolytes. Now coming to the blood picture. Blood picture, if you see, the type of anemia that you will have is normocytic normochromic type of anemia. That is number one. And these individuals, they are more prone for infections. Why? Due to decrease in granulocyte function. Next, they will have bleeding abnormalities. Why is that due to? Due to decrease in platelet activity. So this is the clinical picture that you will have in patients with a chronic kidney disease. And few more important abnormalities. Yeah, due to fluid overload, there will be facial puffiness. There will be development of pleural effusion, pericardial effusion. There will be development of ascites. There will be development of pedal edema, and cardiovascular features will be hypertension. Lung abnormality will be in the form of pulmonary edema. Once there is development of pulmonary edema, these patients will have the acute onset dyspnea, right? So these will be the features of the fluid overload. and these already I have said, the urea can go and accumulate in various parts of the body, and thereby the individual will have the abnormalities accordingly. And the characteristic description is about the nails. Yeah, Haribala, what is your question? How platelet action in renal pathology is related? Yes, Haribala, what happens is the urea which is increased will go and accumulate within the bone marrow, right? This will cause the fibrosis of the bone marrow, and that will affect the platelet activity, or that will affect the platelet count. There will be thrombocytopenia, and that will result in the development of the bleeding manifestations. Okay. Yes, Haribala, is that clear for you? Right. And the characteristic nails that you will have in these patients will be half and half nail. Right, the characteristic nails that you will have is the half and half nails. Okay, and that we call it as the Lindsay's nail, right? Where the proximal half of the nail, right? The proximal half of the nail will be pale, and the distal half of the nail will be dark. Right, the distal half of the nail will be dark. That is what is called the Lindsay's nail, or which is also called half and half nail, right? Now, coming to the etiologies. I said you, what is the most common cause? The most common cause for the chronic kidney disease will be diabetes mellitus, right? And apart from that, you have many other etiologies. You can go through this, but the most common cause will be diabetes mellitus. And very important is this renal artery stenosis. Renal artery stenosis will result in chronic kidney disease, but not acute kidney injury. Please remember this, because for the development of renal artery stenosis, the etiology will be atherosclerosis. And atherosclerosis is not an acute event, it's a chronic event. That is the reason why renal artery stenosis will contribute to chronic kidney disease, but not the acute kidney injury. Genetic disorders like Alport syndrome, where you have abnormality in the alpha 5 chain of type 4 collagen, that will be defective in case of Alport syndrome. I'll be discussing about Alports in detail subsequently. But these are all the etiologies that will be causing the chronic kidney disease. Done? Now, after this, yes, I have already given you this picture. What are the abnormalities in the electrolytes, right? So potassium, magnesium, phosphate increases. Calcium and sodium decreases. Now, can anyone tell me why calcium is decreased in chronic kidney disease? Okay, let me tell you, the calcium which is decreased in case of very good Rituraj Sahu, it is mainly due to vitamin D deficiency in case of chronic kidney disease. And along with that, there is also increase in the phosphate levels. But the primary reason is vitamin D deficiency in chronic kidney disease that will contribute to hypocalcemia. Whereas in acute kidney injury, the hypocalcemia is mainly because of your hyperphosphatemia, right? So this you need to be completely aware of, right? Now, how do you treat these electrolyte abnormalities? What is the important electrolyte abnormality? That is hyperkalemia. So whenever there is hyperkalemia, what is the problem is these patients can develop a complete heart block. These patients can develop complete heart block and they will have cardiac arrest. So in order to prevent, right, in order to prevent the complete heart block and as well as bradycardia, you need to give the calcium gluconate. Drug of choice is calcium gluconate. But please remember, this calcium gluconate will not reduce the potassium. It will only stabilize the myocardial membrane. But what is that particular drug which will cause rapid reduction of the potassium, rapid reduction of the potassium, it is observed whenever you are giving insulin along with dextrose, right? So insulin plus dextrose, that is the one which will cause the rapid reduction of the potassium, right? What it will do, this particular insulin will cause the shift of the potassium from extracellular compartment to the intracellular compartment. The other way by which you can cause the shift of the potassium from extracellular to the intracellular compartment is the beta agonist. Then coming to the furosemide. So furosemide is the one which will cause kaluria, and that will reduce the potassium levels. And you can give phosphate binders which will bind the potassium within the GAT, and it will prevent the absorption of the potassium across the GAT. What are those drugs? Number one, sodium polystyrene sulfonate. But the problem with the sodium polystyrene sulfonate is the intestinal necrosis. Now then, what are the alternative potassium binders? The alternative potassium binders are the patiromer acetate, and the other important molecule is the sodium zirconate. These two are the alternative potassium binders where you don't have this problem of intestinal necrosis, right? Then in refractory cases of hyperkalemia, that means in spite of medical management, if the potassium levels does not reduce, then you need to plan for the hemodialysis. The same way, you need to be completely aware of how to treat the other electrolyte abnormalities like hyperphosphatemia. Hyperphosphatemia, we have the phosphate binders, and these phosphate binders are the sevelamer hydrochloride, and another important molecule is lanthanum carbonate, right? And then the calcium acetate. So these three are the molecules that we give for the treatment of the hyperphosphatemia. Then next important is the calcium gluconate has to be given for the hypocalcemia. And how do you treat the hypermagnesemia? The hypermagnesemia, it is treated with the hydration, or you need to give furosemide that will cause the excretion of the magnesium. So this is how you will be treating the electrolyte abnormalities that you come across either in the chronic kidney disease or in patients with the acute kidney injury. Now, what is the most common cause that we have discussed? Diabetes mellitus. So how do you treat diabetes mellitus? You need to give insulin, but the insulin that you need to give is only 80% of the calculated dose. Why is that we give only 80% of the calculated dose? That is because of the chronic kidney disease, the insulin is not excreted out. The half-life of the insulin will be increased, right? The half-life of the insulin will be increased. So that is the reason why you need to give only 80% of the calculated dose. And whenever you are giving this particular insulin, you have to maintain the HbA1c less than 7%. Okay, so that is how you need to treat the patients with the diabetes mellitus. Then how do you treat the hypertension? So hypertension, the drugs that we give is labetalol, where the target blood pressure that should be maintained is less than 130/80. And these patients with chronic kidney disease, they will have dyslipidemia. Why they will have dyslipidemia? Because of decrease in the lipoprotein lipase activity. So due to decrease in lipoprotein lipase activity, there is dyslipidemia, and the target LDL, it should be less than 70. And for maintaining that target LDL less than 70, you need to give statins, right? Then followed by that, these patients will have vitamin D deficiency. So how do you treat this vitamin D deficiency? You need to give oral vitamin D supplementation. Then coming to secondary hyperparathyroidism. How do you treat these patients will have secondary hyperparathyroidism. Why is that they have secondary hyperparathyroidism? Because these patients will have hypocalcemia. Secondary to this hypocalcemia, parathormone levels increases. So this secondary hyperparathyroidism will cause renal osteodystrophy. So how can you prevent this renal osteodystrophy? That is by giving this particular drug called cinacalcet, which is a calcimimetic agent, which will reduce the parathormone levels, right? Which will reduce the parathormone levels. Okay, so that is about how will you manage the electrolyte abnormalities in patients with a chronic kidney disease. Then followed by that, you need to be completely aware of the renal replacement therapy. So renal replacement therapy is done by two methods. One is hemodialysis. The other one is the kidney transplantation. Whenever you are doing hemodialysis, you need to create a fistula. This fistula, it is created between the radial artery and cephalic vein, and the name of the fistula is the Seminobracia fistula, right? The name of the fistula is Seminobracia fistula. Then what is the principle that you follow in case of the hemodialysis? That will be facilitated diffusion followed by that ultrafiltration. That is what you need to do in the hemodialysis. Now, whenever you are doing hemodialysis, what is the most common complication? That is, the hypotension is the most common complication, because you are taking out large volumes of the fluid and then sending into the dialyzer machine. So that will result in hypotension. There will be accelerated atherosclerosis in case of recurrent hemodialysis. There will be dialysis dementia due to accumulation of amyloid beta 2 protein. There will be development of carpal tunnel syndrome due to accumulation of amyloid beta 2 in the flexor retinaculum. There will be loss of vitamin B5, that is pantothenic acid, that can result in development of burning feet syndrome. And another very important complication is dialysis disequilibrium. So these are the complications of the hemodialysis. And another method by which you can do dialysis is peritoneal dialysis, in which peritoneum itself will be acting as an artificial membrane. And the dialysate that we use here is the dextrose-rich dialysate. This can be done even within the home as well. And the other method by which you can do renal replacement therapy is the kidney transplantation. So here, if you observe the donor and as well as the recipient, what is that you need to do is allogenic kidney transplantation has to be done. The kidney has to be taken from the first degree relative and it has to be placed within the recipient. And please remember, the HLA matching and as well as blood grouping is mandatory. Right? HLA matching and blood grouping is mandatory for kidney transplantation. And for HLA matching, the gene is present on chromosome 9. And for blood grouping, the gene is present on chromosome number 6. And which particular kidney has to be taken from the donor? It is the left kidney. And where it has to be placed? It has to be placed in the right iliac fossa of the recipient, not in the same anatomical position. In the recipient, you have to place it in the right iliac fossa. Once you place the kidney in the right iliac fossa, immediately there is chances of immune rejection. And this particular rejection, it can be of three forms. One is the hyperacute rejection, acute rejection, and as well as the chronic rejection. Now, coming to the hyperacute rejection. So hyperacute rejection is that which occurs within minutes, whereas acute rejection is that which occurs within 6 months after the transplantation, and chronic rejection is that which will occur after 6 months of the kidney transplantation. So hyperacute rejection, it is considered as type 2 hypersensitivity reaction, whereas your acute and chronic rejection, they are considered as type 4 hypersensitivity reactions, right? Now, the next important point is these patients, how is that you can handle the rejection? So you have to give the immunosuppression. You have to give immunosuppression. And that particular immunosuppression, you have to give by cyclosporin, azathioprine, and as well as the prednisolone. So these are the three drugs that you have to give for to prevent the immunosuppression. But whenever you are giving these immunosuppressant drugs, what is the problem? Development of opportunistic infections. So the opportunistic infections that is commonly observed are the MRSA and as well as the herpes simplex virus infection. Then other viral infections are the pneumocystis jirovecii pneumonia, cytomegalovirus, HBV, HCV, and fungal infections like the aspergillus. These are the opportunistic infections which are very common whenever you are giving this, the immunosuppressant drugs, right? So this is about the renal replacement therapy. That is your hemodialysis and as well as kidney transplantation, right? Now, in which group of individuals you will do renal replacement therapy? You have to do renal replacement therapy in those individuals where the GFR is less than 15 ml per minute per 1.73 meters square. And this we consider it as the end-stage renal disease. So in end-stage renal disease, you need to do renal replacement therapy. Done? Now, after having discussed about the chronic kidney disease, we'll move on to the next topic, that is the nephrotic syndrome. My throat is very bad today, right? I'm trying my best to take the session, right? Let me just see if I'm able to continue the entire part. I'll try my best to do. Now, coming to the next important topic, that is nephrotic syndrome. So nephrotic syndrome, what is the criteria? Very important thing is proteinuria. And how much should be the proteinuria? When do we use this estimated GFR? Estimated GFR we use mainly whenever we are calculating any particular drugs. Like for example, aminoglycosides, amphotericin B. Whenever you want to give in a patient with a chronic kidney disease, you need to calculate the estimated GFR and accordingly you need to give that particular drug. That is where we very commonly use eGFR, that is estimated GFR. Okay. Now, so to call it as proteinuria, in case of nephrotic syndrome, in the spot sample, it should be more than 2 grams per gram of creatinine. Whereas in 24-hour urine sample, it is more than 3.5 grams per 24 hours. That is what is the proteinuria in case of nephrotic syndrome. Then coming to the proteinuria, which protein is commonly excreted out? Albumin. And thereby the serum albumin levels will be less than 2.5 grams per deciliter. And albumin is the one which will contribute to the oncotic pressure. Once there is decrease in oncotic pressure, these patients will develop the edema. And the next important is these patients will also have the hypercoagulability due to increase in the synthesis of the coagulation factors, and due to increase in the synthesis of the lipoproteins, they will be having the hyperlipidemia and as well as lipiduria. So these are the features that you will have in patients with the nephrotic syndrome. And in nephrotic syndrome, there will also be loss of globulins, and that will result in globulins are what? Globulins are the one which are required for synthesis of the immunoglobulins, and that will contribute to the development of infections. And there is also loss of transferrin that will result in iron deficiency anemia, and there will also be loss of the cholecalciferol binding protein, and due to which there will be hypocalcemia, and there will be loss of thyroxine binding globulin that will result in the abnormality related to the thyroid disorders, and there will also be loss of ceruloplasmin, due to which there will be abnormality in the copper metabolism. And these patients will have hypercoagulability. What could be the reasons? Due to decrease in the natural anticoagulants. What are the natural anticoagulants? That is antithrombin 3, protein C, and as well as the protein S are being lost. And that will result in the development of the hypercoagulability. So these are the characteristic features in patients with the nephrotic syndrome. Now, if you take the various etiologies that will be causing nephrotic syndrome, right, various etiologies causing nephrotic syndrome, one is your diabetes mellitus, which is considered as the most common systemic disease that will be causing nephrotic syndrome. Whereas in children, what is the most common cause for nephrotic syndrome? That will be minimal change disease. Whereas in adults, the most common cause will be focal segmental glomerulosclerosis. Whereas in elderly individual, the most common cause will be membranous glomerulonephritis. These are the etiologies that will be causing the nephrotic syndrome. Now, out of which, let me discuss about your diabetic nephropathy, which is the most common systemic disease that will be contributing to the development of the nephrotic syndrome. So, in which type of diabetes there is increased chances of diabetic nephropathy? So, the increased chances of diabetic nephropathy, it is more common in type 1 rather than type 2 diabetes mellitus. And in type 1 diabetics, and when will this diabetic nephropathy commonly occur? The diabetic nephropathy commonly occurs when the HbA1c is more than 7%. Right? When the HbA1c is more than 7%. And in case of the type 1 diabetics, within 5 years of the onset of diabetes mellitus, you have the development of diabetic nephropathy. Whereas in type 2 diabetes mellitus, within 20 years of the onset of diabetes mellitus, right? Within 20 years of the onset of diabetes mellitus, you have the development of diabetic nephropathy in case of type 2 diabetes mellitus, right? You take the other renal pathologies. The other renal pathologies that are commonly observed in case of diabetic nephropathy will be, or diabetes mellitus will be, development of renal papillary necrosis. There can also be development of the interstitial nephritis, and there can also be development of type 4 renal tubular acidosis. These are the other renal pathologies which are observed in patients with diabetics. And what will happen to the size of the kidney in diabetics? Initially, there will be enlarged kidney. Later, there will be reduced kidney. And in the first stage of diabetic nephropathy, what is the problem? There will be excessive increase in the GFR, and followed by that, once there is damage to the basement membrane, that will result in microalbuminuria. Then in case of type 2 diabetics, what is that you need to do is, in type 2 diabetics, for the screening of the microalbuminuria, you need to do yearly screening. Whereas in type 1 diabetics, after 5 years of onset of diabetes mellitus, you need to screen for the albuminuria, right? And we have two important forms of the chronic kidney disease. One is diffuse and the other one is nodular glomerulosclerosis. But between these two, which is more common? Between these two, the more common is the diffuse, which is more common than compared to that of the nodular glomerulosclerosis, right? Now, in case of nodular glomerulosclerosis, that is considered as the pathognomic for the diabetes mellitus. Nodular glomerulosclerosis is considered as the pathognomic for the nodular glomerulosclerosis. What is that pathognomic lesion? That is KW lesion, or that is called as the intercapillary glomerulosclerosis. we have one important abnormality in case of diabetics. When the quantity of the blood glucose levels are more than 500 milligrams per deciliter, the glucose is accumulated in the form of glycogen in the proximal convoluted tubule. And that particular change is called as the Armani-Epstein change. That particular change is called Armani-Epstein change. Now, in case of the diabetics, what exactly is the drug of choice? The drug of choice will be ACE inhibitors that will reduce the proteinuria. That will reduce the proteinuria. And in diabetics, what is the treatment that you need to give? The insulin, right? And this particular insulin, it should be given as only 80% of the calculated dose if the diabetics go into a state of chronic kidney disease, right? And this ACE inhibitors will also be used as the antihypertensives as well. But whenever you're giving these ACE inhibitors, you need to monitor the potassium levels, right? Why? Because the ACE inhibitors will inhibit the aldosterone synthesis, and that will cause increase in the potassium levels. That is the reason why whenever you're giving ACE inhibitors, you have to monitor the potassium levels, okay? So this is about the diabetic nephropathy. Yeah, coming to the minimal change disease. Minimal change disease, the other names for minimal change disease is, it is also called nil lesion. Why is it called nil lesion? Because under the light microscopy, you don't have any abnormality seen. That is the reason why it is called nil lesion. Then it is also called as the lipoid nephrosis. Why? Because there is lipiduria, right? Then if you take the age group at which you see this minimal change disease, that is commonly observed in children. And most common cause, it is idiopathic. We don't know what exactly is the cause, but we have some drugs which can contribute to minimal change disease, like NSAIDs, interferon alpha, like rifampicin and all. And what will be the clinical features? These patients, they will be presenting with early morning facial puffiness. Why is that? That is due to albuminuria. The proteinuria that you see in minimal change disease is albuminuria. And once there is albuminuria, the oncotic pressure will be reduced, and that will result in the development of edema, where not only in the facial puffiness, there will be like pedal edema as well, ascites as well, and that can contribute to development of increase in the weight. So weight gain will be there. And these patients with minimal change disease, they will have normal blood pressure. What is the investigation of choice? Biopsy, where the light microscopy will be absolutely normal. That is the reason why it is called nil lesion. Whereas electron microscopy will show you that there is fusion of the podocytes or the fusion of the food process. Why there is fusion of the food process? That is due to loss of membrane anion, that is heparan sulfate proteoglycan, right? And what does the fluorescent microscopy show? Fluorescent microscopy shows that there is no immunoglobulins and as well as C3. What is the drug of choice? Drug of choice will be the prednisolone. Drug of choice will be prednisolone. Whereas in case of the prednisolone, you have to give it for 8 weeks. Then you should taper and stop. But whenever you are tapering and stopping, there can be relapse of the minimal change disease. That we call it as the steroid-dependent nephrotic syndrome. So in patients with steroid-dependent nephrotic syndrome, the drug that you need to give is cyclophosphamide. But in some patients, they don't respond to steroids at all. In that case, you need to give cyclosporin or tacrolimus has to be given. That is in steroid-resistant nephrotic syndrome. So this is about the minimal change disease. Coming to the most common form of nephrotic syndrome in adults, that will be focal segmental glomerulosclerosis, where you have damage to the podocytes, right? Where you have damage to the podocytes. And these patients with focal segmental glomerulosclerosis, they are said to be having this reflux nephropathy. And this focal segmental glomerulosclerosis, you have two forms. One is primary and the other one is secondary focal segmental glomerulosclerosis. Primary, the problem is within the kidney and the gene that is being defective is APOL1 gene is being defective. Whereas secondary focal segmental glomerulosclerosis, that is mainly due to the obesity and as well as the Alport syndrome, or it can be secondary to infections like HIV and HPV as well. And the only form of nephrotic syndrome where you will have hematuria is focal segmental glomerulosclerosis. In minimal change, we have discussed that there is selective proteinuria, but here it is non-selective proteinuria. These patients will be having hypertension. And what is the investigation of choice? The investigation of choice will be biopsy, and you have to take the biopsy from corticomedullary junction. If you take superficial biopsy, there is a very high chance that the diagnosis can be missed. Light microscopy shows that only part of the glomerulus will undergo sclerosis. Electron microscopy will show you that there is presence of the hyaline deposits, and there is also podocyte detachment and as well as vacuolization, and there is also the effacement of the podocytes. And in primary FSGS only, you can give steroids, whereas in secondary FSGS, you need to give you need to treat the underlying cause. And in primary FSGS, only with prednisolone, if the patient is not responding, then you need to give cyclosporin. What is the supportive treatment that you need to give? Furosemide. Why? You have pedal edema, right? And ACE inhibitors, that is mainly to reduce the proteinuria. Why statins? Because there is dyslipidemia. So this is about the focal segmental glomerulosclerosis. Coming to membranous glomerulonephritis. Membranous glomerulonephritis, this is more common in elderly individual where you have the presence of the immune complex deposition. And this membranous glomerulonephritis, it is of two types, primary and secondary membranous glomerulonephritis. And in primary, the abnormality is the antibody is formed against phospholipase A2 antigen which is present on the podocyte. Whereas secondary membranous glomerulonephritis, it is secondary to infections like HBV and HCV. And if you take the course of the disease, 50% of the patients, they go into a stage of end-stage renal disease in case of the membranous glomerulonephritis, right? Now, mainly males, they have very poor outcome. And if the patient is having hypertension, the outcome is not good. And in almost 40 to 50% of patients with membranous glomerulonephritis, there is increased chance of renal vein thrombosis. And on examination, there will be development of the hypertension. And what is the investigations that you will be doing is serum creatinine, if it is being done, that is elevated, that is due to renal failure. But you have to confirm that by membranous renal biopsy, where the light microscopy will show you that there is thickening of the basement membrane and subepithelial deposits are there. Electron microscopy will show you that spike and dome appearance, and fluorescent microscopy will show you that there is IgG and as well as C3. Then how do you treat these patients? Along with prednisolone, you should also give cyclosporin or cyclophosphamide. That is how you treat these patients with membranous glomerulonephritis. And what is a characteristic problem in patients with membranous glomerulonephritis? Immune complex deposition. And very important point you have to remember is renal vein thrombosis. Yeah, Haribala. This dyslipidemia is not observed only in focal segmental glomerulosclerosis. Dyslipidemia is observed in all the cases of nephrotic syndrome. And what is the reason for dyslipidemia? I have already said you, right, in the beginning itself. What is that? That in patients with the nephrotic syndrome, you will be having hyperlipidemia and as well as lipiduria. Why they will have hyperlipidemia? That is due to increase in the synthesis of the lipoproteins by the liver in patients with the nephrotic syndrome. There will be increase in LDL and VLDL. This increased LDL and VLDL will be causing hyperlipidemia. So that is observed in all the cases of nephrotic syndrome. All right. Is that clear, Haribala? Right. So in nephritic syndrome, the quantity of the proteinuria that you will have is less than 3 grams per 24 hours. And that we call it as subnephrotic proteinuria. That we call it as subnephrotic proteinuria. And the another important abnormality will be the hematuria, where you have the presence of RBCs in the urine. That is what is your nephritic syndrome. And in these patients, you will have oliguria and as well as the hypertension. And if you take the etiology, the immune complex depositions are very, very common. The immune complex depositions. So if you take this, the immune complex depositions, these patients, the immune complex deposition can be secondary to post-streptococcal glomerulonephritis and as well as the infective endocarditis. Then what are the multi-system diseases? Multi-system diseases that can contribute to the development of nephritic syndrome will be Goodpasture syndrome, then IgA nephropathy, and as well as the post-streptococcal glomerulonephritis. These are the multi-system diseases that will be causing the nephritic syndrome, right? Then what are the drugs that will be causing nephritic syndrome? That is penicillamine. These are the drugs that will be causing the nephritic syndrome. So these are the etiologies that will be causing nephritic syndrome, out of which let me discuss about the post-streptococcal glomerulonephritis. So this post-streptococcal glomerulonephritis, it is secondary to infection by group A beta hemolytic streptococcal infection. So this group A beta hemolytic streptococcal infection, either it can cause throat or the skin infection. So throat infection is more common in winter and skin infection is more common in the summer. So if you take the throat infection, like the latent period is around 1 to 3 weeks, and skin infection, the latent period is around 3 to 6 weeks. And the serotype which is most common in throat infection that is causing post-streptococcal glomerulonephritis will be serotype 12. And in skin infection, the serotype will be 49. And the age at which the post-streptococcal glomerulonephritis is very common is 5 to 15 years. The clinical features that you see is very commonly hematuria, where you will have the presentation of the child in the form of a cola-colored urine. Then the presence of the urine analysis you will notice that there is RBC and as well as RBC cast. Then if you take the serum complement levels, there will be hypocomplementemia, and that too there is transient decrease in the complement levels. And within 4 to 8 weeks, the complement levels will return back to normal. And in the serology, very important is there will be elevation of the ASO antibody titer. What is the investigation of choice? Biopsy. Biopsy, light microscopy will show you that there is glomerulonephritis and neutrophilic infiltration. Electron microscopy will show you that there are presence of dome that is due to subepithelial deposits. And in immunofluorescent microscopy, you will have this IgG and C3 that will give you a starry sky appearance. And how do you treat these patients? You need to do only conservative management. In post-streptococcal glomerulonephritis, there is no role of antibiotics and there is no role of steroids as well, right? So for hypertension, you need to give ACE inhibitors, and for edema, you need to give diuretics. And overall, the prognosis in patients with post-streptococcal glomerulonephritis is a good prognosis. The recurrence is very, very rare. And the problem here is immune complex deposition. So because it is immune complexes which are deposited within the glomerulus, and that is the reason why this will contribute to the development of, or this will result in development of a type 3 hypersensitivity reaction. Okay, so this is what is the problem in patients with the PSGN. Coming to the next important etiology that will be causing nephritic syndrome, that is IgA nephropathy. So IgA nephropathy, the another name for this is Berger's disease, right? Or it is also called as mesangial-proliferative glomerulonephritis because there is proliferation of the mesangial cells, right? And here the IgA will go and deposit within the mesangial cells, resulting in mesangial proliferation. And this IgA nephropathy, this will occur 2 to 4 days after the development of the upper respiratory tract infection or gastrointestinal or urinary tract infection. And the clinical features that you will see in case of the IgA nephropathy will be the hematuria. That is a classical presentation. But in these patients with IgA nephropathy, they don't have hypertension. Blood pressure and urine output will be absolutely normal. Exactly contrary to that of your post-streptococcal glomerulonephritis, the recurrence is very high in patients with the IgA nephropathy. Whereas the biopsy, if you observe, there is presence of the IgA in the mesangium. IgA in the mesangium, that is observed in the immunofluorescent microscopy. Contrary to post-streptococcal glomerulonephritis, the serum complement levels will be absolutely normal. In PSGN, we have discussed that there is transient hypocomplementemia. And how will be the course of the disease? There is high chance of recurrence. That is also contrary to your post-streptococcal glomerulonephritis. And in PSGN, there is no role of steroids. But in IgA nephropathy, you need to give steroids and as well as cyclophosphamide. And the type of hypersensitivity reaction that you will have in case of IgA nephropathy will be type 2 hypersensitivity reaction, whereas in post-streptococcal glomerulonephritis, it is type 3 hypersensitivity reaction. So this is what is the difference between the IgA and as well as post-streptococcal glomerulonephritis. Next important abnormality, that is Goodpasture's syndrome. So if you take Goodpasture's syndrome, it's an autoimmune condition. Even this will contribute to the development of the nephritic syndrome. And type of hypersensitivity reaction is type 2, similar to that of IgA nephropathy. And it's a multi-system disease. What are the organs which are affected? Lungs and as well as the kidney. Now, when I'm using this word autoimmune, the antibodies, they are formed against the alpha-3 chain of type 4 collagen. The antibodies are formed against the alpha-3 chain of type 4 collagen. And the clinical features that you will have is mainly hematuria and as well as the hemoptysis. These are the clinical features that you come across in patients with the Goodpasture syndrome. And if you take the serology in patients with the Goodpasture syndrome, serology, you have the presence of the antibodies. Serology, you have the presence of the antibodies. But the antibody, that is anti-glomerular basement membrane antibody, it is present only in 90% of individuals. And if you take the biopsy, immunofluorescent is the one which will show you the presence of the linear deposits of the antibody. And electron microscopy will show you that there is presence of the crescents. And chest X-ray will show you that there is presence of diffuse infiltrates because there is also lung involvement in these individuals. And the first line treatment here will be plasmapheresis. And the maintenance treatment in these individuals will be corticosteroids. Because corticosteroids are the one that will prevent the antibody formation. And in refractory states, you need to give rituximab. So this is what is your Goodpaster syndrome, where the antibodies are formed against the alpha-3 chain of type 4 collagen. Next, coming to the Alports. Alports, the abnormality is against alpha-5 chain of type 4 collagen. And in Alports, it is characterized by a triad. What is a triad? Glomerulonephritis, sensory neural hearing loss, then anterior lenticonus. This is what is a triad in patients with the Alport syndrome. So this is the problem in patients with the Goodpaster syndrome. All right. So multi-system disease, hematuria, and as well as the hemoptysis. Done. Next. Followed by that, so we are done with the nephritic syndrome, like post-streptococcal glomerulonephritis, IgA nephropathy, Goodpaster syndrome. The next important topic for the discussion will be polycystic kidney disease. So polycystic kidney disease, it can be inherited in two forms, autosomal dominant and autosomal recessive. But between these two, which is more common, autosomal dominant is more common than autosomal recessive. And autosomal dominant type of inheritance is observed in adults, and autosomal recessive type of inheritance is observed in children, right? And what is the age of presentation of this polycystic kidney disease? The age of presentation is around third to fourth decade. By almost sixth decade, they go into a stage of end-stage renal failure. That is by almost 60 years. And in order to develop this polycystic kidney disease, the genes that are being mutated are the PKD1 and as well as PKD2. PKD1 gene is present on chromosome number 16, and PKD2 gene, it is present on chromosome number 4. And the cysts in the polycystic kidney disease, they are filled with a straw-colored fluid, and these particular cysts are distributed throughout the cortex and as well as medulla. And because of the presence of the cyst, there is enlargement of the kidney, and that can result in development of the loin pain. But these cysts, there is increased chance of the infection that will result in the development of acute pain because of increased risk of urinary tract infection. And 75% of individuals, they will develop hypertension. And the complications that you come across is 20 to 30% of individuals, there will be development of the urate stones because the urate is or uric acid is not excreted out. And if you take the extrarenal manifestations, the cysts are not present only in the kidney, right? Cysts are present not only in the kidney. The cysts are also present in the liver, spleen, ovaries, and as well as the pancreas, right? And gastrointestinal tract abnormalities also can be there. That will be in the form of colonic diverticulosis. Cardiovascular abnormalities can be there in the form of mitral valve prolapse syndrome, and CNS involvement can be in the form of berry aneurysms. Whenever they rupture, that will result in subarachnoid hemorrhage. What is a first line investigation? You need to do USG abdomen to look for the enlargement of the kidneys and as well as cysts. But confirmation is being done by the CT abdomen. The treatment that you need to give is ACE inhibitors for hypertension. Tramadol you have to give for pain control. Quinolones you need to give mainly for reducing the chances of the urinary tract infection. And why is that particularly you need to give quinolones? Is you need to give lipid-soluble antibiotics, which has to cross these particular cysts and kill the organism. So what is that lipid-soluble antibiotics? That is quinolones. And sirolimus is the drug which can prevent the progression of the disease of your polycystic kidney disease. So this completes the discussion of this very important topic, that is polycystic kidney disease, right? Yeah. So these are some of the very important topics in the nephrology.